Mine is actually a recap of the talk. Sir had already shown a live in box, which had almost all of the steps. But the thing is, troubleshooting is of leadless pacemakers can be either during the implant. There are many implant related problems. For a beginner, these might be important because there are many, although it's probably a 10 minutes procedure for a micro or a VR implant, there are many potentially hidden problems and post-implant problems can happen. First is a venous site injury. I'm going by the procedure order. So if we, about 0.6 to 1.7% venous site access injury incidence is reported in the CED data and micropar data. So that can be well avoided by a dedicated ultrasound guided puncture. These days, most of us do ultrasound guided puncture. This will avoid through and through injury through the artery, or sometimes the vein may be collapsed, especially in elderly. So that also prevents through and through, and also the vein may be collapsed, especially in elderly due to dehydration, etc. So next is sometimes always you have to guide you can take a contrast injection through the delivery sheath once you put halfway through, so that you can know whether there is any venous issues beforehand itself, as and when you put the delivery sheath. Or what we can do is you initially insert a thermo wire with a JR placed along with a JR, and with the catheter placed in SVC, exchange with to an amplatz tip wire. That also prevents venous injury, so that on that you can track the large delivery sheath. So IVC tear is very rare. That can be life-threatening, but it's not been reported with any of the micro implants. So next is anomalous anatomy. Although azygous continuations, there are reported cases of implantation of leadless pacemaker with azygous continuations. There will be sufficient length, mostly because the catheter is sufficiently long outside. So, but what is recommended is a jugular vein approach in such cases. Another difficulty is it is very difficult in micro implant in small right atrium. Some elderly with may have very small right atrium. So either with AVR or with micra, the implant is going to be difficult because entry into the atrium and the curvature is going to be difficult. While in micra it is a pull down, as was told, and while in AVR it is a push up. So both might be difficult in a small right atrium with a difficult tricuspid valve. Sometimes you may have to make a U-turn with a catheter. At that point, the problems are either the patient may go into vasovagal if you are not gentle with it, or sometimes you can create an AV block or an RBVB may occur if there is injury to AV node or bundle. So our right ventricular, as sir told, although it is not a must to do a RV angiogram, but it's always better to do in the initial part of your experience to do an angiogram to understand the anatomy, because the diagnostics are always good. Always in micra, try to get to the, even in micra, you tend to go to the slightly upper space so that you get an upper septal implant, which will give you a better QRS than a lower septal implant. So even in micra, you tend to go slightly higher, but always keep in watch the RV anterior sign in RIO view. So you need to have some space there, so that will avoid perforations. What it does is avoiding very anterior apposition of the micra, so of the pacemaker, so that there is no pericardial effusion. So generally basal implant will give a better ECG, but the problem with basal implant, very basal implant, will be TR. Because even though that is less with micra because of the lower length of the device, and more with AVR. With AVR, you need to go to this area, almost 6. This area will be the AVR implant, while micra will be somewhere 5. That will be the area of implant of micra. So another problem is, suppose the LV is very calcified, then you are going to get or scarred LV. You are going to get very high thresholds with either of the implants, either screwing or active or passive. In such cases, sometimes you may have to actively resort to other places like anterior area, anterior wall, etc. This happens especially with restrictive cardiomyopathy like pictures. So you may have very calcified LV, and it will be very difficult to sometimes screw in or place it the tines. So the threshold might be very high. This is something which is possible. Especially after implant, if the impedance is acceptable, which is what they say is impedance less than 500 is not very good. There is a higher risk of higher thresholds post implant. So if the impedance is acceptable more than 500, then if it's a tine lead, then it is probably better to wait for some time, as sir had told, wait for 5-10 minutes, it will, especially if there is a good current of injury. If there is a good current of injury, just wait 5-10 minutes. The current of injury subsides, and when that subsides, you can recheck the threshold and impedance. You will find that most of the time threshold has come down. And if the high threshold is persisting, one thing that you have to suspect immediately is a thrombus on the device. So just recapture and remove the whole system, check for thrombus on the tip of the device, and then reattempt. You will often find better thresholds. Thrombus prevention is basically with adequate heparinase. That's the most important step. Even though sometimes it's not required if it's a 10-minute procedure, but if it's a longer procedure, difficult anatomy, sometimes you may have to, you'll have thrombus in the tether, so which will be a problem for both of the devices. So IV heparin 2000 can be given just after serial dilatation of the vein, and 1000 units can be added to the saline infusion, and 2 saline infusions, 1 to delivery sheath, and the delivery catheter can be maintained. And pericardial effusion, present incidence with experience is now 0.8%, is very low. Sometimes you have to be careful. That is one importance of taking an angiogram through the delivery sheath is, sometimes this was a case reported of a coronary sinus implant of a micra. So this is an inadvertent implant, and patient had a pericardial effusion and which had to be surgically removed. So these are very rare complications, but it can happen. Sometimes it may require surgery. And generally, pericardial effusion incidence risk factors are more than 85 years, BMI of less than very thin patient, female gender, heart failure, prior MI, and patients who have no surgery before. Post-CABG patients are relatively better. They had less perforations. Patients with COPD and hemodialysis, renal failure patients are at a higher risk. And microembolization risk are quite, they are low, 0.06%, this is micro data. It can happen either acute or late, and it can happen, this one micra in LPA, so micra in RPA, both can be taken out with triple snares. There are multiple off-label off-label devices, and even a dedicated Senju device also is there, snare now with Avier. And device infection is quite rare. It's reported 0.013% is quite low, and only 2 cases of device infection has been reported in the large CED data. And TR is something which is of concern because it's a late complication. We can't do anything at the time of implant. It can occur later, but at the time of implant, one echo probe, putting an echo probe just post implant is very good to see whether TR is there or not just before releasing the device. So TR will be less with micra because of the lower length of the device, especially if we put a mid-septal implant. But if we put a basal implant, there is going to be a high incidence of TR. And with post-implant problems, device programming. Basically, leadless, the good thing is that it just mimics the physiology. So what we are detecting is basically A1 is just like S1, A2 is S2 closure of A and P valves, and A3 is the area that we are interested, because what we want to pick is just A4, whether there's any atrium mechanical systole. This is atrial mechanical systole which is detected. So we want to program, what is programmable is this window, whether there is any activity during this time. This is the time when blood comes from atrium to ventricle, and that is what we want to detect. That has to be just before the A4. So this is the area where we are interested. So what is programmable is, the device has multiple vectors because it can be positioned in any device, any position, because the body orientation is so much variable. So we can't have a particular vector, but there are multiple vectors provided inside the device. So what we can program is the A3 window and the A3 threshold. A3 threshold and the A3 window is what we can program. So these 3 parameters is what we can program: A3 window, A3 sensitivity, and A4 sensitivity. All 3 can be programmed. It is very variable, so it is individualized for each patient. Post procedure, you have to take patient outside and check the best vector possible. Only one vector, 1 or 2 vectors will be best, so you can pick up the best vector available. So okay, thank you.
One quick question to you. What is the time frame of this pericardial effusion mostly you see?
It can happen, suppose it can happen very acute, because during our, suppose a very anterior implant, you can have immediately. And suppose this coronary sinus published paper, it was a very late one, like second or third day they had understood that there is pericardial effusion.
And was it self-limiting or it went into tamponade?
Yeah, that patient went into tamponade.
Okay. And second is about your migration of the device into the PA. How late it can migrate?
One thing is, I think there was one implant, it had embolized, because one problem is the TPA, temporary pacing lead. After pulling out the tether, everything, the last pull out of temporary is, you have to be very careful. It can embolize at that point of time immediately. Next moment it may be in PA. But there has been no report. I don't know whether Hasra sir knows. I don't know whether any late embolization is extremely rare, not heard of.
Over the of the micra, particularly suppose at 45 of age, every 7, 8 years, 10 years. So how many 2, 3 of the micra?
Up to 3 is what is maximum. Recommended.
Yeah.
But I think probably now with that will not be a question in the future, because 16, 17 years device is coming. So I think it will be a thing from 45 years, probably we can start thinking of micras.
Yeah. And regarding fibrillation, defibrillate of the device if necessary. Yeah,
Defibrillation as such, there is no nothing, there is no data and all which has come. Probably it should not embolize, but at what time we can defibrillate is also not yet known. We can only speculate, maybe not immediately. If the patient is in AF, you won't immediately cardiovert. Maybe you will wait for 6 weeks or something.
Yeah.
Thank you, Dr. Sreekumar.
Sir, one quick comment. So when we do a micra AV, so there are some of the important points are there. So the micra AV, when we implant, during the implantation, there is no sensitivity testing happens.
Yeah.
So someone feels that just after the procedure, patient will have a AV synchrony, VDDR pacing, it is not going to happen. The atrial sensing setup will happen in next 4 hours.
Yeah.
So you just look at the threshold in the,
Only threshold.
in the cath lab. You put this device in the right place. You look for the R and pacing threshold, and then bring out the patient. And also the mechanical sensing will set up in next 4 hours, and then there will be VDD. And when we program this test, like atrial mechanical MAM test, which we say, we have to be careful about one of the programming features in micra AV, that is AV conduction mode switches. So one patient I implanted a micra AV, and that I got a ECG at around 45 heart rate, complete heart block. There was no VDD going on. So I thought, what's wrong there? Then I had not switched off this micra AV conduction mode switch, because the micra wants to pace and not to go in VDD mode if the heart rate is not falling less than 40. Someone is complete heart block at 45, 50 heart rate, the micra will not go for VDD pacing. So otherwise you have to stop this micra AV conduction mode switch. So just a reverse of what we see in normal dual pacemakers. So this is a little difference in the micra program.
And if the heart rate is higher, AV synchrony is going to be low.
Yeah.
So we may have to use a beta blocker also, post micra implant.
Okay.
Thank you, Praveen.